For the introduction. It's a great honour to be giving the David Schiff Lecture, and just hearing just reminded me, I mean, those days these guys worked night and day. 100 hours a week was absolutely nothing. And sometimes I go to meetings of the young doctors and they say, do you know, it's really hard. I've worked 45 hours this week. But guys like David Schiff dedicated their life to getting it all going, and certainly we have been able to build on what they did. So I just got one or two slides I've been asked to show you. You've seen that. I have had honoraria for lectures from 3 companies you see there. I have consulting fees from the other 3 companies there. With Fisher and Paykel, my consultancy is to try and improve some of their products. I give them a lot of advice and they take absolutely no notice of it. But that's quite true. I keep telling them the NIPPV is about 25 years old and needs to be completely overhauled, and they say yes, and we still go on getting the same old machine. Anyway, that's where we are there. I'm going to present you, as best I can, the state of science and knowledge about non-invasive neonatal ventilation. It's not my intention to promote or endorse any specific product. So here we are, non-invasive neonatal ventilation. And actually it's been a bit of an agony for me putting this together because you all know about non-invasive ventilation. So please don't fall asleep when I'm telling you stuff that you know. I put ventilation in quotes because this is my first theme, really. Don't believe the words we use. And this has been a real problem. So, continuous positive airway pressure. CPAP, we use it all the time. It's pressure, isn't it? Is it? Or is it flow? We'll come back to that. But because once high flow started coming in, everybody said, oh, we don't like high flow. It doesn't produce the same pressure as CPAP. Well, perhaps CPAP actually produces the same flow as high flow. So we have to be very careful not to believe this. And then we've got this non-invasive positive pressure ventilation. Does it ventilate? Answer, no. But because we call it NIV, NIPPV, we believe that it's ventilating, and we get that in our head and we don't think beyond that. Anyway, I'll come back to these things. So, a big discussion, not quite so big discussion now as it used to be, high flow on nasal cannula, and I go back not quite to the David Schiff area, but not that far, and we were thrilled when we learnt to ventilate babies. We were really good. Pretty good, fairly good at that. And then, damn it, CPAP came in. And you can use CPAP instead of ventilating. No, we've got to intubate all these babies at birth, and CPAP, that's all right for, you know, George Gregory and putting babies in boxes, but we've got to ventilate them. And because we then realised that CPAP was terrific stuff. I'll tell you more. And then, damn it, when they thought we knew about CPAP, high flow comes in. No, with high flow can't be any good. We've got to give CPAP. So then we're in the situation, which do we use and when do we use them? So CPAP, that's been half my life, is trying to understand and talk about CPAP. It's amazing stuff. I mean, CPAP, just simple application of a low pressure to the airways, particularly at birth, helps clear the lung fluid, establish aeration, improves oxygenation, conserves surfactant. You can read all the list of good things it does there. Halves the need for ventilation if you start CPAP early. It does everything that a neonatologist could possibly want. But it has problems, and I think I'm about the worst of anybody telling people CPAP's wonderful and not acknowledging that actually it's got a lot of problems. It requires skilled nursing care. Now here you are in Edmonton, and I've just been in Calgary. You've got very skilled nurses, and so it's easy. But you go to other parts of the world, their nurses aren't so skilled. And not long ago I was in Korea giving a lecture about CPAP, and at the end a big boss stood up and said, "Thank you very much, CPAP doesn't work in Korea." Well, you better come to Australia and we'll teach you how to do it. And it really boiled down to that the nurses did not have the experience and skills. And if you aren't skilled at doing it, it's very difficult. And look at this poor old baby there. It's got great thick hat. It's got everything strapped around its face. Yes, we might be making it better with the CPAP, but we're making it jolly uncomfortable as well. And bigger babies get agitated. CPAP, by definition, has to be a tight fit of the prongs in the nostrils, and that makes the baby's noses sore. And I was in Calgary, and they say, "We don't get sore noses in Calgary with CPAP." And I, well done, you're very good. And I'm sure that's true, but most people still do. You can perhaps see on there condensation in the prongs. And this can be a problem. Water condenses in there and gets blown into the baby's nose. And I've seen babies, if you're not careful with this, big drops of water are getting blown in and the baby has a desaturation and problems. Perhaps you wouldn't recognise that. So where have we got with high flow? Well, you know this, I don't really need to go in it, but it's usually oxygen, some flow between about 2 and 8 litres. We still don't know what is the right flow. But it's thin cannulae, less than half the diameter of the nostrils, and it must be heated and humidified. I should have put that in the CPAP. Ventilation. We must make sure the gases are heated and humidified. And those of us who've been around for a long time know that we've tried giving high flow for years, but it was cold, dry gas coming out of the wall. And what happened? A few hours, baby's nose was just full of thick secretions. And we were in big trouble trying to suck it all out. No, we can't do this. Now we have these really good heating, humidifying devices, then we can do it. The other thing you have to remember with high flow, it's not like CPAP, which has got an expiratory valve on the ventilator or a bubbly bottle where the excess gas, as it were, is being vented. All the gas, all that flow, let's say it's 6 litres, going in through the equipment, goes into the nose and must come out again. And please, please do not block the mouth and the nose, otherwise there's going to be a nasty mess all over the nursery. It's a lot of gas coming in, it must come out, and that's one of the reasons that the prongs need to be small. So who's using it? I'm sorry this slide is a little bit old, but the basic message is that it has swept across the world. So suddenly, over the course of a very short time, we went to find that a large number of units are using high flow. And there are units, I mean, Oxford in England use high flow all the time and say, I don't believe them, but they say they never use CPAP at all, because I have spies in there that tell me. But so, and when I first, I was very resistant to high flow. I said, this can't possibly be any good. And I know a lot of these people, and I thought, they're crazy. I mean, fancy going for a treatment like that that's not going to work. Now I thought, actually, these guys are quite clever. They must be seeing something that I'm not. And so then I started thinking, right, we've got to understand high flow. So here's a slide I was given by my Australian colleagues of the use of respiratory support in babies less than 32 weeks, just over a few years. And it's interesting, CPAP still being used a lot. High flow is coming up, and I think if we were to plot the last 3 years, you would find that it was well over 50% of the little babies are getting high flow. But interesting, what has caused a bit of concern to the administrators who pay for all this stuff is that the incidence of CPAP and ventilation is not really going down, but high flow is going up. So we're giving more treatment. Okay, so why do people love high flow? And my experience is, if you don't use high flow, don't let the nurses get their hands on it. Because as soon as the nurses start using high flow, they want to go on using it. And the mothers want you to use it. It's simple. It's very easy. We'll show you data, but as you know, it's pretty effective. Minimal nasal trauma. And walking around the nursery in Cambridge just recently, there was a baby on CPAP, and the mother said to me, do you think you could ask the doctors to put my baby on high flow? Because the mother of that other baby says it's so much nicer to the baby. And the mothers talk and they see what's happening. And you can nurse the baby, you can cuddle the baby, you can breastfeed the baby, you can bath the baby, you can do all sorts of things. Much easier. You can do those on CPAP as well, but so much easier. Okay, so there's me, permanent skeptic. How does high flow work? What's it doing? So yes, it might be good, but what's it actually up to? So we go back to 2009, and I think this was a simple, good summary of what we know. But the first thing on there, it's washing out the nasopharyngeal dead space. So you've got a big flow going in through the nose, coming back out of the nose a bit, but also coming out of the mouth. So there's fresh gas, completely washing out the upper airway. So as the baby breathes, it's getting fresh gas from just above the larynx. And so that makes the breathing, the minute volume, much more efficient. CO2's a bit lower, and it reduces the whole nasal resistance because that's been bypassed by all the flow. And one of the questions that gets asked is, well, what flow should we use? Well, the principle is that the flow should be higher than the peak nasal inspiratory flow of the baby. I won't ask you what it is because we don't know what it is, but it's roughly 3-4 litres a minute. And why do you want a higher flow than that? Because you don't want the baby taking a big breath and entraining room air. You've decided this baby needs 30% oxygen and you want it to get that. You don't want it bringing in air at the same time. And I put there, it increases airway pressure. So how much does it increase airway pressure? And the critics of high flow think, oh, well, might be, but it doesn't give that CPAP pressure. Well, let's just have a look at the pressure. So there's a number of studies, and because of time I have to jump through some of these things, forgive me, but this is a study from my colleagues in Australia. Just 10 babies, relatively big, not very sick, with, according to their inspired oxygen, a number of problems, but they measured pharyngeal pressure with a catheter tip transducer. So that's a good way of knowing exactly what the pressure is. Quite difficult to measure pharyngeal pressure otherwise. Why did they use a catheter tip transducer? Well, it just so happened Dominic Wilkinson's dad was professor of pediatric cardiology, so some of the catheters went from the cardiology lab to the neonatal unit. So they looked at the effect on the pharyngeal pressure of flows between 2 and 8. And here is the graph that they produced. Flow along, oh, it's a bit washed out, isn't it? Flow along the bottom, pressure up the side, and you can see as the flow goes up, the pressure goes up, and you could draw nice lines through it and say, look, isn't it wonderful? There's lovely correlation between the two. But you have to say, look, we're clinicians. We like to see this sort of graph, but what we're really interested in is I want high flow to give me a CPAP pressure of 5 centimetres in the pharynx. What flow do I need to do that? And the answer is, well, some babies 2 litres and other babies nearly 8 litres. So you cannot have a flow that is going to give a set pharyngeal pressure. Or if you say, right, I'm going to give a flow of, let's say, 4 litres here, what sort of pressure will I get? And the answer is, well, I'll get anything from 3 till about 10. So, oh, okay. So,
per kilo? Sorry, per kilo or per minute? Or per kilo per minute?
That's flow in litres per kilo. Don't know who put minute on there. That was stupid, wasn't it? Okay, we bypass the errors in the lecture. Okay, so this was given to me by Brad Yoder, who many of you may know. I mean, there's more studies now, but it just shows the principle. So the green is the study I've just shown you. Goes up quite well with flow, mean pressure. Others don't quite show as much, and people have said, oh, this is very strange. But I think the message is, look, get your brain in gear. What could possibly be happening? Pharyngeal pressure. If the mouth's wide open, you're not going to have much pressure. If the mouth's closed, you're going to get more pressure. Okay? If the cannula are very tiny or bigger, you're going to get transmitted. The flow rate's going to make a difference. The size of the infant and its nose. You know, if you've got a big nostrils, it's going to make a difference with the cannula. You've got tiny little nostrils, it make a difference. How much snot there is in the nose. And look, of course it's going to vary. You can never expect that a certain flow is going to give a certain pressure. And then we have, well, actually, what about CPAP? You know, this is all going to apply to CPAP as well as high flow. So with CPAP, is the pharyngeal pressure the same as the set pressure? There's an intelligent looking guy. What sort of pharyngeal pressure do we get? Let's say we got 5 centimeters of CPAP. What pharyngeal pressure would you expect to get? 5? 6?
Plus or minus 2.
Plus or minus. So more or less 5. You're wrong. So Tony DePaoli did his thesis on looking at pharyngeal pressures in babies on CPAP. And this is bubbly bottle CPAP. That's why the CPAP pressure is the red line, and it's bubbling as the water bubbles out of the bubbly bottle. The air bubbles out of the bubbly bottle device. And we've got 2 pharyngeal pressures being measured, just in case one wasn't working very well. And what you see here, if you look at the beginning and the middle section with the mouth open, although it says it's giving a pressure of 7, the pressure in the pharynx is only 3. Okay, and so many people think I've dialed up a certain pressure. That's what the baby's getting. But it's not surprising. There's a big hole in the system. You know, you don't need a very big hole to let out a lot of gas when there's some pressure there. Then in this study, they actually held the baby's mouth closed, and the pressure goes up, not surprisingly, to more or less the same. Not entirely the same, because there's still leak around the prongs. Now, when we saw this, we thought, wow, this is a problem, isn't it? I mean, we're giving 7, but we're not getting 7, we're giving 3. So we walk around the nursery, and we say, we've got to bully the nurses to keep these babies' mouths shut. We've got to get this. And so off we go. And we see half the babies on CPAP look like this. Mouths wide open. And we say to the nurse, oh, how's your baby? Fine. Next one. Mouth open. How's your baby? Terrific. Having apnea? No, doing well. And then we realised that this is what's happening with most babies. I mean, they might not have their mouth open as much as this one, but even if it's just slightly open, you don't need much of a hole to let gas out. And so we realised that this is what's happening, is that you think you're delivering a certain pressure, and you believe it, but, you know, simple physics, you're going to lose a lot of the pressure because of gas escaping out of the mouth and round the prongs. So here was just a little more of Tony DePaoli. So here's set pressure, there's the pharyngeal pressure. And if the mouth's open, you can put the pressure up. And how many of you say, whoa, 8 centimeters of CPAP? Whoa, it's a bit dangerous, isn't it? And what are you getting? About 3 or 4. Close the mouth and you get more pressure, but you certainly don't get the same pressure as you think you are. Okay, so with CPAP, how much flow goes through the nose? My fall guy in the middle. You shouldn't sit there, should you? Right, Georg, how much flow goes through the nose with CPAP?
Good question.
You don't know?
I don't know.
Does anybody know?
No.
No, you don't know. Oh, somebody does. Oh, right.
I think it's 8 to 10.
Sorry?
So you set the flow, but
No. You see, what you're confusing the set flow that goes in, but if you've got a bubbly bottle system, you can see a lot of it's coming out. What you want is what is actually going through here, not what's in the circuit. And the answer is, we don't know. We don't know. We never think about it because CPAP's pressure, isn't it? Why should we think about flow? So, but actually, I'll show you in a minute a little study here that we did, and to my embarrassment, we never published it because we weren't interested in high flow in these days. We just wanted to know what leak there was from the mouth. So this is bubbly bottle CPAP with a flow, let's say, of 6 litres, and it turned down the flows till just stop bubbling. It's one of my party tricks. You turn down the flow, stop bubbling, you've still got the pressure, hey, we got 6 litres. Where's it all going? Not coming out there. It must all be going through the prongs. It must all be going in and then coming out of the mouth and nose. So 48 recordings. This was a bit quick and dirty stuff, but anyway, the principle is there. The flow median, 3 litres. Anything up to 10 litres. Hey, wait a minute, isn't this the sort of flow we use for high flow? Oh, perhaps CPAP's giving high flow. Perhaps it's not that pressure after all that's causing all the way. It's the high flow. Lift that question in the air, I can't answer that, but you just got to start thinking about these things. So, funny little print, something's gone a bit wonky. CPAP, variable pressure, high gas flow through the nasal pharynx. You begin to see that CPAP and high flow are working in the same way. All right, enough of me waffling, let's have a bit of data. Trials of high flow after birth for RDS. So this is primary support, they call it. And the outcome in this trial, this was failure of treatment in the first 7 days. 4 trials, just over 400 infants. And the difference, failure of support, death, chronic lung disease, no significant difference. Other things were reported in some of the trials, pneumothorax and everything else, but they weren't reported in all of them, so they're not here. But the answer was, there isn't any great difference in outcome between CPAP and high flow, but there were no tiny babies. So don't rush off and think we can do it to the tiny babies. Now, presented at PASANS, sorry, these were meant to fill the slide, but doesn't matter. Presented at PASANS was the results of the HEPSTER trial. This is a trial, an international trial, but started from Melbourne, Australia. Big babies, greater than 28 weeks. First 24 hours, requiring support. Randomized to high flow, 6 to 8 litres, or CPAP, 6 to 8 centimetres. Primary outcome, treatment failure in the first 72 hours. But the high flow group could, if they failed high flow, could get rescue CPAP. And they had non-inferiority targeting a margin of 10%, and they needed 750 babies. But after 564, the Data Safety Monitoring Committee stopped the recruitment because they said that there was too big a difference between them. So these are big babies, 31 weeks, but treatment failure, 25% of the high flow and 13% of the CPAP. Intubation rate, 15% of the high flow, 11% of the CPAP. And this was what they said, okay, you're not, even if you go on for your 750 babies, you are not going to be able to overcome that difference. Less nasal trauma, that's what we see with high flow, but no difference in other outcomes. So we've got those other trials saying there isn't really any difference, and then here we're beginning to see that actually high flow is not so good in these babies as primary support. So limited data, we really haven't got any decent data on babies under 28 weeks, and that's what we're worrying about, looking after most of the time. Efficacy and safety is not that well investigated. We still need more information, I think. And so I think my message is don't rush to give high flow as primary support at the moment. Right, post-extubation, this is where high flow really has come in and what's being used by most people. 6 studies, about 1,000 babies. No significant difference in death, chronic lung disease, treatment failure, less nasal trauma with high flow, no significant difference in pneumothorax perforation, NEC, IVH, sepsis, retinopathy of prematurity. High flow and CPAP post-extubation seem to be having remarkably similar effects. Sorry, I keep saying some of the fonts changed in some of my slides, but don't worry. So we've now got 900 babies randomized, all have used heated humidified, all have used gas flows 2 to 8, still don't know what's the right one, and high flow and CPAP have similar efficacy. So this is what made me begin to think, you know, they're probably working in a rather similar way. But we do like a bit of pressure in some circumstances, and we need to work out how much is flow and how much is pressure. Okay, now I just come here. There's 2 slides which just make us sort of sit back and wonder. So this was a large retrospective cohort from the Vermont-Oxford database. It's slightly strange, but this has been well published. 5 centres who primarily used high flow versus the rest. So lots of babies. Babies' characteristics similar between the centres. The Vermont-Oxford centres that used CPAP on 69% and the high flow centres used high flow in 73%. Fewer infants in high flow centres died, had infections, BPD or went home, so their conclusion was, hey, yippee, high flow seems to be pretty good, there's no obvious adverse event, trend to better, and of course we've got the other randomised trials, particularly in post-extubation. So when are we going to use high flow? Or what should we do? Small bronchs, don't block the nostril. Must be properly heated and humidified. Flow somewhere between 4 and 8. Probably the best thing is to look at how much oxygen the baby's needed, and if the FiO2 is a bit high, then you put the flow up, and as you wean the oxygen, then you can reduce the high flow. But that's not very evidence-based, that's what people are doing. And the failure criteria are the same as CPAP, and I'm not going to go into that. That's another lecture, not to say an argument. Okay, so when do we use it? Post-extubation, it really looks good. Kangaroo care, easier nursing, mothers love it. Don't give it at birth at the moment, and early RDS, probably not. Apnea, what data there is limited, is that it might have a bit of effect on apnea, but I'm not pushing that. Bronchiolitis, paediatricians in the audience, I'm not going to talk about bronchiolitis, but hey, high flow treatment has swept through the paediatric world in bronchiolitis. All right, coming towards the end, a few more slides. NIPPV. Okay. Right, I just got a slide there saying synchronized. So what we've got here is nasal, we've got a technique that increases the pressure. I'm not going to call it ventilation, as I'll show you in a minute, okay, against CPAP. And you can either just do it, say to the baby, I'm sorry baby, but you're going to get a pressure every now and then, whether you like it or not, or you can synchronize it. And there are various techniques. The Graysby capsule on the abdomen is the one that's been used most and actually seems remarkably effective. People have tried flow triggers. I'm not impressed. Pressure triggers, no. RIP bands, yep, they work, but you've got to have the baby lying still. Don't move it, which is not possible. NAVA, we've got our NAVA friends here. Looks good, interesting data. I haven't had any experience, and I still would like to see a bit more data, but it is a technique which is being used. So NIPPV, I have to use that term, or BiPAP. Most studies have actually used ventilators, and they try and use pressure settings that they were using before the babies were extubated, but they can vary. 14 to 24, CPAP 3 to 6. Flow drivers can deliver NIPPV and BiPAP. The CPAP machine, which is used a lot, just remember it doesn't deliver very high pressures. I mean, it'll get up to 15 if you're lucky. Whereas if you're using a ventilator, you can aim for higher pressures. So NIPPVs try to mimic ventilation without using an endotracheal tube. BiPAP is just one pressure level, another pressure level, and it's holding them for much longer. So here's a meta-analysis of using NIPPV against CPAP for extubation. 8 trials, quite good, 1,300 babies. 5 of them were synchronizing. Some of those were old trials, no longer got the equipment to do that. Non-synced, both. 6 had ventilators, etc., etc. And it showed that NIPPV showed a significant reduction in reintubation. Synchronized NIPPV had even less ventilation, no differences in major outcomes, but a reduction in air leaks with NIPPV, if you believe it. Okay, we'll come to that in a minute. All right. So then we're beginning to think NIPPV seems to be working, and then Harish Kirpalani does his big study, 1,000 infants, quite small infants, okay? NIPPV and CPAP used at any time in 28 days. And it sort of frustrates me that they had such a, and they used any device, and it could be synchronized or not, okay, and they were enrolled either at birth or after extubation. Primary outcome, death or BPD, okay, no significant difference between NIPPV or CPAP. Oh, well, we got beginning to think that NIPPV was pretty good, and I'm sure lots of you are using NIPPV because you think it works. And this trial showed that it didn't make any difference. So then we have to dissect out what was really going on, and I'm not going to do that here today. So what about the conclusions from NIPPV? Non-synchronized doesn't seem to be any better than CPAP. And that's what most of us are doing. No benefit for apnea. After birth, not really making any great difference. Synchronized better than CPAP post-extubation. And so we got some data, and there's lots of experience that NIPPV works. And how might it work? I'm always, okay, it works. What's it actually doing? So Louise Owen did a PhD on trying to work out what was going on. And she put rip bands around the baby and got the signal and the ups and downs of the baby breathing. Okay, and what she showed was there is a large variation in pressure delivery. So set pressure, 20. Median pressure that was actually being delivered to the prongs was more like about 12. And so there was a lot of loss of pressure. And so that was large variation. Pressure prongs lower than the set pressure. And the higher you put this peak pressure, the bigger the difference was. But it still increased the mean airway pressure, of course. And so we began to think that any advantage of NIPPV versus CPAP may be just due to the high mean airway pressure. So if I say to you, right, you've got your baby on 6 centimeters of CPAP, put it up to 10. You say, I can't put it up to 10. I'll put it on NIPPV. And you're putting the mean airway pressure up to 10 without knowing it. Okay. So, and the other thing is that the pressure wasn't getting to the lungs. And this is why I say it doesn't really ventilate. So I've got a recording or two here. Along the top is the pressure increase. There's the CPAP and the pressure increase. And then here you can see let's go for the sum. This is the chest moving. So there's the pressure starts, and that's right at the peak there, and just happens to be the peak there, and it's coming there. But if I just showed you that trace, you would not know that the baby was receiving peaks of pressure. It's not being transmitted. Here's another one. So here we've got a few more, and you can see that because it's not synchronized, it's just before, just on top, just after, right after, just before. So it's coming in at different times. And it's a bit like ventilation. Why give non-synchronized ventilation? Why try and give an inflation to a baby when it's breathing out? And certainly the baby didn't really have much effect. It doesn't have much effect. So here I just got for interest, I'm sorry it's all a bit washed out, but I hope you can see, CPAP. Lots of you are using CPAP here. So does CPAP synchronize? And the answer is, here's the Gravesby capsule going forward, and there's the pressure delivery, and here it's synchronizing remarkably well. All breaths trigger CPAP, and the pressures were as set until you get up to the baby breathing fast, and then it misses. So only alternate breaths were being triggered by the CPAP, and not surprising, the pressure fell overall. Now, how often are you going to be going that fast? But really, Louise's message was synchronizing with CPAP is good up to about 60. Get much beyond 70 and it's not synchronizing nearly as well and dropping out. Another thing of showing, does the pressure go through to the baby? Well, here's apnea, okay. Is it central apnea or what is it? We don't quite know, but you can see that the Gravesby capsule, the RIP, showing absolutely no deflections. Nothing's getting through, oxygen's going down. And so another bit of, little bit of evidence that it's not causing any trouble. So where are we now with NIV? Non-synchronized NIPPV that doesn't ventilate, well, might do a tiny bit, but it doesn't really do much. Any benefit might be from increasing the pressure. But we don't know what device, we don't know what pressure, we don't know what rate. There's still a whole lot of research needed. But I think if I was getting involved in this now, I'm not, synchronizing the pressure waves. Perhaps I should call them inflations, because if you synchronize them to the baby's inspiration, you do get some transmission. So I won't go through that because time's getting on. That's really my story about non-invasive ventilation. I'm happy to take questions. Thank you very much. Any questions?
Is there any questions from the remote sites?
Ja, ik heb ook nog voor Alex. Thank you, Matt, for after the excellent review of that review.